ladies, it's Kim Bukta here today again to do another video. In today's video, I want to go over menopause hormone therapy. And again, for those of you who have not watched some of my other videos, I am a physician assistant, but I'm in orthopedic trauma, so I'm not in women's health, I'm not in OB. I have developed an interest in women's health and longevity just as I'm going through this perimenopause, menopausal transition, as there's not a lot of information you're getting from your provider, but there is a ton of information on the internet, so it's hard to kind of siphon through what we should actually be following. So I've just done a lot of research on my own, and I wanted to share what I've learned with women. Again, I'm not your provider, so I'm not providing medical advice. I'm just providing my opinion and what I'm doing with the research that I've learned. So I'm just hoping that this helps other women kind of clarify things. The main takeaways from today's video is, one, I want women to realize that hormone therapy is safe for most women. There's low risks for most women, and that there appears to be a lot of benefits. So again, that's takeaway point number one. Takeaway point number two is that every woman should have a conversation with a knowledgeable provider that understands this information and that knows the woman's health history, so that they can go over the risks and benefits, and they can help you make that decision on whether or not you want to choose menopause hormone therapy or not. It's not for everyone, and that's fine, but you should at least have the conversation and get the information so that you can make your own choice. So I would recommend doing this for most women if you're watching this video when you're younger, before you're in the throes of these awful symptoms in perimenopause. So I think in your early 40s, or when you're just first starting to have symptoms, it would be beneficial to find a provider that is knowledgeable on this and can kind of go over the pros and cons of these different treatment options, so that you have a decision of kind of what you want to do before you become super symptomatic. Because let me tell you, it's not fun when you're feeling awful trying to find a provider that can help you with this. So again, I'm on my third provider. I'm now using the online MIDI health resource. Again, they're menopause specialists, and they are more knowledgeable and can actually help me go over things. A lot of the other providers are just too busy. So a lot of primary care providers and OBs are just too busy in their practices to be up to date on all this information. And again, it was not taught in medical school, PA school, MP school. So you're gonna have to do this research on your own. So it's hard for a lot of providers to be up to date on this, and it's not their fault. So again, just making sure you find a provider that can help you have this conversation and understand, you know, the risks and the benefits for you, because everybody's different, and help you make the decision on what's right for you. Now, there are a ton of different formulations for menopause hormone therapy, whether the systemic or the localized, like the vaginal estrogen. So I'm not going to go over all those different formulations today. Again, that's a conversation you'll need to have with your provider who's going to write for this, because everybody's different on what they want to do. So again, that conversation should be had with your provider that's going to be writing for this. But one main takeaway point though is, women, if you have a uterus, you will need to have estrogen as well as progesterone. If you have had a hysterectomy and don't have a uterus, you can just have the estrogen component. So that's the only thing I wanted to mention about the hormone therapy. So what I wanted to do today is I actually want to read over the Menopause Society's guidelines on what their recommendations are for hormone therapy, or kind of their position statement. Anyone can access this. It's about 50 slides on their website, and anybody can read these. I'm going to just highlight the kind of level 1 data, just because I think this is more pertinent for, you know, medical providers on making their decision. This is the, you know, good scientific evidence based on randomized controlled trials or meta-analyses. So this is the information that a lot of providers use when making medical decisions. So I just want to kind of go over those highlights. Again, there's a lot more information on their website. If you want to read all the slides, you definitely can log on and do that yourself. Another great resource you can check out is the book Estrogen Matters, and that kind of goes over how estrogen benefits your whole body, kind of system by system. So again, women, I feel like research this so that you are knowledgeable this on your own, because again, you're going to get a lot of information and you need to make the decision on what works best for you. So with that being said, I'm going to apologize because I'm actually going to read from the paper today so I don't mess up this data. So I'm just going to kind of go over this level 1 data so that you guys can kind of understand this and help make the decision for yourself. So let's get started. So the first thing they talk about is that the absolute risks associated with hormone therapy are rare. It is less than 10 per 10,000 per year for risks. And those risks are mainly blood clots and gallbladder disease. And the risk is even lower with the newer formulations that are out there. So like the transdermal patches, the gels, or the creams, the risks for those two side effects are even lower because you avoid the first pass effect through the liver. What does that mean? When you take the oral pill, it has to go through the liver, and that's where these side effects can happen. And again, those side effects are still very low, but they're even lower when you do these other transdermal options. In studying the Women's Health Initiative, it did show that absolute risks associated with hormone therapy is reduced for all-cause mortality, is reduced for fracture, and for diabetes in the population that was age 60 or younger. So that shows you that women younger than 60 had reduction in those things. So all-cause mortality, fracture, and diabetes. What they found from hormone therapy with coming out of the Women's Health Initiative, what is it approved for by the FDA? It's approved for moderate to severe vasomotor symptoms. It's approved for the prevention of osteoporosis and for the treatment of primary ovarian insufficiency, which just means you go through menopause before age 45, and for the treatment of moderate to severe vulvovaginal symptoms. It is also used to treat genitourinary symptoms of menopause, but if you don't have other symptoms, they'd actually recommend you just use vaginal estrogen instead of the systemic hormone therapy. So let's go over what first are vasomotor symptoms. These are our hot flashes. So this is what women can have. It can last anywhere. The average is 7.4 years, but some women are having them even into their 70s. And there is a lot of data out there that shows there is increased risk for stroke and other bone and brain associated risks if you have bad hot flashes that are not treated. So this is kind of important, women, that if you are having moderate to severe hot flashes, the gold standard for treatment is hormone therapy. And if you don't treat these, there are some long-term health risks associated with this. Hormone therapy also improves sleep in women with these bothersome vasomotor symptoms. Now, the genitourinary symptoms of menopause. So what are these? This would be your frequent UTIs, your urinary incontinence, vaginal dryness, itching, pain with sex. If you have other symptoms other than just these genitourinary symptoms of menopause, they would recommend the systemic hormone therapy. If you just have the genitourinary symptoms of menopause, they would recommend just vaginal estrogen, just because, again, this is not absorbed systemically. So it is safe for almost every woman to treat if you're just doing the vaginal estrogen. But again, if you have other symptoms, they'd recommend the systemic hormone therapy. Now, this is hormone therapy will not improve your sexual desire. It does increase, however, lubrication, blood flow, and sensation to those vaginal tissues. But if your concern is libido or sexual desire, then you want to talk to your provider about testosterone. The one caveat with that is a lot of the research and data I'm seeing is a lot of providers want to put those pellets, so testosterone pellets in for women, and this does not appear to be a really good option. And I would definitely talk to your provider about not doing this, because once they put those in, they can't regulate. I mean, you're stuck with that for 3 months, and women's testosterone levels are really high, and they can have a lot of side effects with these. And again, you can't do anything for 3 months. So if your provider is wanting to do the pellet testosterone, I would kind of steer away from that and try to do more of the creams and make sure they're checking your testosterone levels when they're treating you for that. So again, testosterone is for low libido. The hormone therapy is better for, your urinary symptoms, your vaginal dryness, lubrication, pain with sex, because it can help with all of those things. Now, there is some data that shows there is beneficial effects of estrogen on skin thickness, elasticity when given at menopause. There is also systemic hormone can improve menopause-specific quality of life in women experiencing menopause symptoms. Hormone therapy is FDA approved for osteoporosis prevention. Hormone therapy prevents bone loss in healthy postmenopausal women with dose-related effects on bone density. It reduces fracture risk in healthy postmenopausal women by 20 to 40%. Once you discontinue the hormone therapy, it results kind of in rapid bone loss again. So it just kind of maintains it while you're on it. Once you go off it, you kind of go back to the rapid bone loss again. And what the Menopause Society statement says is, in the absence of contraindications for women with menopause symptoms aged younger than 60 or within 10 years of menopause onset, systemic hormone therapy is appropriate therapy to protect against bone loss. Another finding is that women in the Women's Health Initiative studies have had less joint pain and stiffness with hormone therapy than compared to placebo. Estrogen's decline in menopause contributes to sarcopenia, and what that means is loss of muscle mass. And there are preclinical studies that suggest possible benefit of estrogen therapy when combined with exercise to prevent loss of muscle mass and strength. What they also found in the Women's Health Initiative is that hormone therapy significantly reduced the diagnosis of type 2 diabetes. The menopausal transition is associated with an increase in body fat, as we all know, and a decrease in lean muscle mass, which results in that increased visceral fat and decreased metabolic rate. And although hormone therapy may help attenuate the fat accumulation and weight gain, the effect is small. So they didn't really see a major benefit of helping with weight loss or helping women from gaining a lot of weight. So again, that was a small effect with being on the hormone therapy. And I kind of noticed this myself. So again, we'll need to rely on the fat loss and helping maintain our muscle mass is what we've talked about in the other videos with our protein intake, our strength training, our sprint training. Those are all discussed in the other videos on kind of how to maintain your muscle mass. Now, the Menopause Society guidelines also state it is not recommended to take hormone therapy to prevent or treat dementia. So they don't recommend it. However, there is a lot of new data coming out that is very beneficial and talks about the timing hypothesis, that if you start hormone therapy within that 10 years of menopause, there's evidence suggesting a reduced risk of dementia. So again, I think even though the Menopause Society states that you shouldn't use this for primary treatment of dementia, there's a lot of promising data coming out that it can help lower your risk of developing dementia if you start it within that 10 years. Again, so I think there's going to be a lot more research to come on that one. Cardiovascular disease is another big topic. And what the Menopause Society states is that for healthy, symptomatic women under 60 or within 10 years of menopause, the favorable effects of hormone therapy on coronary heart disease and all-cause mortality should be considered against potential rare risks. There are a lot of observational studies that show estrogen is beneficial if started within 10 years and can reduce your risk of coronary heart disease and overall mortality. And they do this through the modulation of your lipid profile. It enhances your endothelial function and it reduces inflammation. Now, it's not to say too, I know women who are over the age of 60 are worried, that kind of excludes me. It's not to say that you can't start it over age of the 60, but you really need to make sure you find a provider that is going to check your cardiac risk factors and make sure you're safe. Because if you add estrogen to already diseased vessels, you definitely increase your risk of stroke and other heart disease and problems. So again, you don't want to add hormone therapy if you already have cardiac risk factors. So again, women over 60 need to really make sure they find a provider that can evaluate for them and make sure that they are safe to start that. But there's that benefit. It's noted that under 60 or within 10 years of menopause, that it can have that cardioprotective effect. There's also observational studies that suggest reduced risk of colorectal cancer with being on hormone therapy. So that was kind of going over a lot of the benefits. And again, risks are low. So the main risks that they noted in Women's Health Initiative would be the blood clots and the gallbladder disease. Now, the breast cancer risk was the big thing that came out of the Women's Health Initiative, and that was the big scare that had everybody stop taking hormone therapy. And I want you to know that that study was kind of flawed in the fact that the women that were in that study were already 10 years out from menopause. So the average age of the women that were in that study were 63 and older. So I feel like you already have the disease cells that you're adding the estrogen to. What the Women's Health Initiative has stated now is that the risk for breast cancer is low with hormone therapy, with a rare occurrence of less than 1 case per 1,000 women per year. And if you read more data about the study, there actually may be no difference on hormone therapy to not on hormone therapy, as they were comparing their placebo group, which this group of women actually had been on hormone therapy prior to being enrolled in the study. So their risk of getting breast cancer was actually lower than the general population. So it looked even more dramatic when you were comparing the placebo group to the group getting treatment, just because they had a lower risk than the general population of getting breast cancer. So if you look at the Menopause Society statement, it is a low risk of developing breast cancer on hormone therapy. Again, less than 1 case per 1,000 women. Or if you look even more into some of the other data research out there, they said it might be actually no difference. So again, low risk to no difference depending on the resources you kind of look at. So again, I want to make sure people understand that. So I've kind of gone over things, and what I really wanted you to get from this video is it's your choice on hormone therapy or no hormone therapy. You just need to find that provider that's going to help go over the benefits and the risks for your health history on if it's a viable option for you. The main risks documented, remember, are basically blood clots and gallbladder disease, and those risks were low. Remember, it's less than 10 per 10,000 per year, and that was with the oral formulation. So that's a low risk with oral, and even now most people are switched to patches and gels, so that risk is probably even lower than that. And remember, the breast cancer risk is also low if you look at the new data of how they've actually evaluated the Women's Health Initiative data. And there are definite benefits. Again, looking at the cardioprotective effect, the protection against bone loss, maybe this neuroprotective effect. So again, there appears to be a lot of benefits. So I think for women that are within 10 years of their menopause transition or under the age of 60, that's where they're noting this healthy cell hypothesis, where you're just adding estrogen onto your already healthy cells, and it's something you've lived with your whole life. So that's where they're seeing the benefit. So I think it's worth every woman having this discussion with their provider. I feel like every woman needs to do the research and understand the data. I personally did start hormone therapy. I've started about a year ago, and I noticed a dramatic difference. I obviously felt like myself again. It was amazing to all of a sudden start this and feel normal again. I'm still struggling though, however, with getting the right dose, just because when I started, they started me on Prempro, and I felt amazing. Like all my symptoms went away. It was great. I was sleeping great. I had no hot flashes. I had no heart palpitations. So I was like, it was amazing. I'd never felt, I mean, it just felt good. And it was like, you didn't realize how bad you felt until you felt good. But I was bleeding so much that, again, when I met with the other providers, we figured we should actually go to the transdermal patches and the oral micronized progesterone, since again, there's just a little bit lower risk of some of these other side effects. So, but with doing this, a lot of my symptoms have returned. So trying to find the right dose, again, it's kind of been a struggle, because a lot of the providers I've been working with are making me stay up for 3 months while I was trying to figure things out. So again, it kind of sucks when you're feeling bad for 3 months, trying to find the right dose. So again, now I'm working with MIDI. They are much more reasonable, and we're trying things for a month and kind of adjusting doses. So stay tuned. I will keep you guys posted on what I end up for final dose. But again, even with being on this stuff, I still feel way better than I did on not on anything. Again, this is a decision that is up to each woman. You just need to get the information and make the decision that's best for you. I hope these videos are helpful. I hope this information is helpful. Again, this was on the Menopause Society's website. And again, I feel like this is a great resource, because this kind of goes over the guidelines. Again, that book Estrogen Matters is a good resource. So checking these things out for yourself. If you like these videos, please, share them with other women so they can get this information. Hit like and subscribe. And some of my other upcoming videos, we'll discuss, should you check hormone levels? We'll go over vaginal estrogen kind of separately. We'll kind of keep trying to make a video a week of new information to kind of help educate us as we're going through this transition. Hope you found this helpful, ladies. I appreciate you listening. Thanks. See you next time.